Moving on to the next lecture. It's going to be done by Professor Kazuo of Fujihara. I don't think he need any additional introduction to this audience. Over to you, sir, to talk us on update on NMOSD.
Thank you very much. Hello again, everyone. So in this presentation, I would like to update you on NMOSD, but today I would like to focus on treatment. So these are my disclosures. So let's first look at what is NMOSD. And as you see here, roughly 40% of the patients become legally blind, at least in one eye, of 5 years after onset. And 1 out of 5 patients may require walker at 5 years after disease onset. And up to half of the patients may require hospital admission within a year of first NMOSD attack. And as you all know, up to 90% of the patients are positive for aquaporin 4 IgG. And finally, if untreated, 90% of the patients may require hospital admission. So it's a severe disease, and essentially the disability of NMOSD is attack-driven. So preventing relapse is critically important for the better long-term outcome of this disease. So as I list here, there are various situations in patients with NMOSD in terms of treatment. But in the interest of time, I would like to focus on 4 situations. Patients who had an attack, in terms of acute phase treatment, relapse prevention, a patient who had a relapse despite immunosuppressive treatment or other monoclonal antibodies. Maybe I will skip the issue of patient with desire for children. And finally, the patient with seronegative NMOSD. So let me start with acute phase treatment. Needless to say, probably the first-line treatment for NMOSD attacks in your center is high-dose IV methylprednisolone. But as you see here, complete recovery is seen in only 20% of the cases. Then, as a rescue therapy, you may choose plasma exchange. But here's a French study that showed the relationship between when plasma exchange was started and the percentage of the good response. And as you see here, if you start plasma exchange after 5 days of attack onset, attack response rate becomes much, much lower. So as Professor Lekar Pandit emphasized, you have to start the treatment as soon as possible. So these authors cautioned that perceiving plasma exchange as a rescue therapy, only IV methylprednisolone failure, after only IV methylprednisolone failure could be detrimental. You may miss the window of opportunity. So PLEX may be considered as a first-line treatment. This slide shows the proposed mechanisms of action of plasma exchange. Of course, it removes the pathogenic antibodies and pro-inflammatory cytokines, but it can impact the cellular immunity as well, T cells and other cells. And here's data of the changes of peripheral blood lymphocyte subsets in NMOSD attacks following immunoadsorption plasmapheresis. probably immunoadsorption plasmapheresis is commonly used in Germany, in Japan, some other countries, but not all the countries. But here's the data generated by Professor Nomura at Saitama Medical University in Japan. And following the IAPP treatment, activated CD4 cells decreased, and helper inducer cells also decreased. But on the other hand, NK cells with regulatory functions increase. So again, plasma exchange and immunoadsorption, plasmapheresis, not just impact humoral immunity, but also impact cellular immunity. Recently, German NMOSD group published a treatment strategy of NMOSD. Here's their figure of a treatment strategy of NMOSD attacks. So as I mentioned, in most cases, IV methylprednisolone is the first-line treatment, but if a response to IV methylprednisolone was insufficient in the previous attack, you may go directly to either plasma exchange or immunoadsorption plasma exchanges. And if the response is insufficient, then you may add high-dose IV methylprednisolone. And then they suggest to continue oral corticosteroid treatment up to half a year. And then if the patient is positive for aquaporin 4 IgG, then you have to start long-term immunosuppression right away. But if your patients are double negative for AQP4 and MOG, you may start such long-term treatment after second attack or after first severe attacks. This slide shows the three most commonly used off-label drugs to treat AQP4 positive NMOSD, rituximab, mycophenolate, mofetil, and azathioprine. And as for efficacy, they can reduce the risk of relapse by around 70% or up to 50%, depending on the drugs. And you may need to be careful about low immunoglobulin levels for rituximab, teratogenicity, hair loss, and skin cancer for mycophenolate, and increased incidence of malignancy and bone marrow suppression for azathioprine. As for the cost of the treatment, rituximab is a bit more expensive, but yearly cost of mycophenolate and azathioprine treatment are much less than $10,000 US a year. But as you all know, in recent years, the first ever randomized controlled trials for aquaporin 4 IgG positive NMOSD were done, and some monoclonal antibodies were approved. Eculizumab and more recently ravulizumab are the anti-complement C5 monoclonal antibody, and satralizumab and tocilizumab are anti-IL-6 receptor monoclonal, and rituximab anti-CD20 and inebilizumab CD19 are the B-cell depleting treatments. In the randomized controlled trials, they were proven to be highly effective in reducing the relapse risk. For eculizumab, 94% risk reduction, and satralizumab and inebilizumab, nearly 80% risk reduction of relapse. Anyway, all of them are highly effective. And as for safety, since eculizumab inhibits complements, you have to pay attention to the meningococcal infection. And for satralizumab, a risk of hyperlipidemia has been described. And for inebilizumab, hypogammaglobulinemia and impaired immunity may occur over time. But compared to those three off-label treatments, these newly approved monoclonal antibodies are very expensive. So that may limit approval and availability in some countries. Let me explain the situation in Japan. For acute exacerbation, IV methylprednisolone, plasma exchange, or immunoadsorption plasmapheresis, and for AQP4 positive optic neuritis that did not respond to IV methylprednisolone, we can use IVIG. And for relapse prevention, these 5 monoclonal antibodies have been approved, one drug in a year since 2019. And so far, this is a rough estimation, but over 300 Japanese patients with NMOSD have been treated with eculizumab, satralizumab, over 1,700, and inebilizumab, about 200. For rituximab, we do not know the exact number of the patients treated with monoclonal antibodies. Ravulizumab was approved only recently, but as I will tell you later, ravulizumab can be given once every 8 weeks rather than once every 2 weeks for eculizumab. So I think most of the patients treated with eculizumab sooner or later will switch to ravulizumab. Azathioprine has not been formally approved, but the government decided to reimburse for this treatment. And as for the genetics test in terms of the efficacy or the side effect of the drugs, for eculizumab in Japanese population, 3.5% of Japanese people harbor C5 missense variation. If your patient harbors this genetic variation, eculizumab cannot bind to the C5 to block the breakdown of C5 into C5a and b. So you cannot expect that therapeutic efficacy in these patients. Well, 3.5%, 1 out of 29 patients, which is not extremely rare. So we advise Japanese neurologists to test these genetic variation prior to the first dosing of eculizumab. And as for azathioprine, people from Western countries are familiar with the TPMT gene mutation, which is associated with leukopenia. But this gene mutation is relatively rare in East Asian population. And instead, NUDIX hydrolase 15 or NUDT15 gene polymorphism is relatively common, and this polymorphism is associated with the significant risk of leukopenia and alopecia. So again, we have to check this genetic polymorphism before we start azathioprine treatment. Again, German NEMOS group reported the treatment strategy of AQP4 positive NMOSD. Well, it seems that the situation in Germany is similar to our situation in Japan, and they can use these monoclonal antibodies from the beginning if they want. So they are listed as the first choice, or depending on the situation, you may use azathioprine, mycophenolate, or tocilizumab. But if the second choice does not work, you can switch to the first choices. And if one drug is not effective, you may switch to another one which has a different mode of action. Let me show you the eculizumab monotherapy results. And as you can see here, very few patients experience relapse. In this analysis published a few years ago, 96% of the patients were free from adjudicated relapse, and those patients had no disability worsening. But as for infection that occurred during the treatment, although I mentioned that you have to focus on the meningococcal infections, other types of infection did occur, like pneumonia, acute cholecystitis, urinary tract infection. So you have to pay attention to any kind of infections. We recently reported a post-marketing survey, 2-year result of Japanese patients treated with eculizumab. In this 2-year analysis, around 70% have been enrolled, but only 1 relapse. And as you see here, most of them were treated with corticosteroid before they started the eculizumab treatment. Steroid doses were decreased significantly. So over time, they may be able to discontinue the immunosuppressive treatment, which is important in reducing the long-term side effect of those treatments. For some reason, in this study, C5 polymorphism was not seen in any of the ones who were tested for this gene test. And fortunately, no meningococcal infection were recorded. But one thing, when you consider switching from rituximab to something else, from eculizumab to something else, most likely rituximab, recently Turkish doctors reported very important results. So 7 out of 10 patients who joined PREVENT study, which is an eculizumab trial, and open label extension, and they completed the trial, but 6 of them had to discontinue eculizumab due to reimbursement issues. And most of them switched to other treatment, likely rituximab. But very importantly, 4 of the 6 patients who discontinued eculizumab had early relapse within 3 months. So all had high disease activity before eculizumab treatment, and during eculizumab treatment, there was no relapse at all. So when you switch from eculizumab to something else, you may have to worry about the early relapse that develop before the switch drug show any therapeutic efficacy. So it's quite important. So as I mentioned recently, longer-acting complement C5 monoclonal ravulizumab was approved in Japan and in some other countries. And ravulizumab is engineered to release C5 in endosome as pH levels drop and use neonatal FC receptor to recycle back to the bloodstream, leaving C5 to be degraded by the lysosome. More specifically, so this is ravulizumab, IgG, and at FAB portion, 2 amino acids were substituted to promote dissociation from C5 in endosome. At FC region, 2 amino acids substituted to prompt binding to neonatal FC receptor. So by using this monoclonal, you can promote recycling of the antibodies. So that's why ravulizumab can be given once every 8 weeks rather than eculizumab's once every 2 weeks, which is important for busy patients, busy in work, school, child rearing. So as I said, I guess the majority of the patients who were treated with eculizumab eventually switched to ravulizumab. Recently, the ravulizumab trial was published in Annals of Neurology, but in this trial, ravulizumab was compared to placebo, but they did not enroll newly enrolled placebo patients. They used the placebo data in the PREVENT. And as a result, in ravulizumab group, no relapse at all, but in placebo, 20 of them had relapse. And unfortunately, there were 2 cases of meningococcal infection in the ravulizumab group, but they were treated relatively soon, and they recovered without any sequelae. So next, let me talk about satralizumab, IL-6 receptor monoclonal antibodies. And last year, there was a long-term efficacy reported in Neurology N2. And as for the time to first relapse, 70% of the BEM were relapse-free. And as for severe relapse, 90% of the patients were relapse-free. The same is true for sustained EDSS worsening. But compared to the data in eculizumab, ravulizumab, efficacy rate is a bit lower. And also, many relapses occur in the early phase of the treatment. So we may need to think about what we can do to reduce the risk of relapse in this phase of the treatment. Recently, a Japanese group reported the effects of actually tocilizumab, IL-6 receptor blockade treatment on immune cells. And for example, neutrophils are increased in NMOSD, but as a result of the tocilizumab treatment, it reduced significantly. And regulatory T cells increase as a result of tocilizumab treatment. And the same is true for CD56 high NK cells with regulatory functions. So neutrophils functions are suppressed and the regulatory lymphocyte functions are increased as a result of IL-6 receptor monoclonal treatment. Next, let me talk about the B-cell depleting therapies. This slide shows the B-cell lineage and the expression of CD19 and 20 in the lineage. And as you can see here, CD19 is expressed wider range of cells in this lineage. Actually, if you treat patients with CD20 monoclonals, of course you can deplete CD20, but the CD19 positive cells survive. That's a worry. Then what about the results in inebilizumab randomized controlled trial, which is a momentum study? So these patients were treated with rituximab, and red dots are the relapses. So despite the rituximab treatment, these patients experience relapses. However, most of them, after they enter the inebilizumab trial, I'm sorry for these Japanese words, rituximab and uplizna, which is a trade name of inebilizumab. You can see that there are very few relapses during inebilizumab treatment. Professor Ho-Jin Kim's group once reported that Fc gamma receptor 3A F allele is associated with the risk of relapse while receiving rituximab and insufficient depletion of memory B cells. But inebilizumab is glycoengineered, more specifically defucosylated to enhance affinity of low affinity immunoglobulin G Fc region receptor 3A and maximizes ADCC. So F allele is surprisingly seen in up to 40% of the population for homozygous. So it's a big worry. But although I do not go into the details, recently in momentum study, investigators reported that regardless of the Fc gamma 3A polymorphism, inebilizumab was able to reduce the risk of relapse in these patients. Needless to say, during the inebilizumab treatment, you have to focus attention to IgG levels. Over time, immunoglobulin levels decline. However, so far, there's no relationship between the IgG level and the risk of infections. Also, in momentum studies, cell damage biomarkers were analyzed after the RCT was completed. And and it was found that at attacks, serum neurofilament light chain was strongestly associated with the disability worsening. On the other hand, as for a predictor of relapse, serum GFAP was shown to be a predictor of upcoming attacks. And also, at the end of the randomized control period, fewer inebilizumab-treated patients had serum NFL level higher than 16 picogram per ml than placebo-treated patients. So inebilizumab treatment can suppress the neuroaxonal degeneration. Finally, the treatment strategy of double negative NMOSD. They suggest to treat those patients with rituximab first, or depending on the situation, as a thiopurine or mycophenolate. Recently, Jackie Pallis's group at Oxford published a very nice overview of double negative NMOSD. It seems to be rare, and it seems to be a syndrome rather than a single disease, ranging from a monophasic illness to a syndrome, chronic syndrome, indistinguishable from AQP4 positive disease, or may develop into other mimics such as MS. But this study shows that double seronegative patients' serum GFAP was not increased. So this category of this disease is not astrocytopathy. And recently, a European group measured the serum GFAP and tau and the UCHL1. So these are the neuroaxonal damage biomarkers. And compared to the AQP4 positive disease, the GFAP and some neuroaxonal damage markers are significantly lower. So it seems to be a different disease. And the German group reported some efficacy of IL-6 receptor monoclonal in these populations. And in momentum studies, only 9 patients were double negative NMOSD, but compared to the pre-treatment relapse rate, there was significant reduction of relapse during the inebilizumab treatment. To sum up my talk, well, not just the medical factors, but also patients' lifestyle should be considered in deciding on the treatment in individual patients. And needless to say, earlier the treatment studies, the better the prognosis is. And the treatment switching should be considered at relapse or severe adverse events. And some biomarkers may be useful to assess treatment effect, disease activity, and so on. Although I did not have time to mention symptomatic treatment, it's also important to improve quality of life. Finally, treatment of seronegative NMOSD is still in the development phase. Thank you so much for your attention.
Thank you, Professor Fujihara, for that very interesting talk. We can perhaps allow one burning question. Yes, Roger.
Thank you very much for this very nice presentation. In relation to the Turkish paper, the senior author being Axel Silva, right?
Yeah.
You know the washout period between stopping eculizumab and starting rituximab?
Well, I do not remember the detail, but I don't think the washout period was too long, because eculizumab is once every 2 weeks administration. So I think they recognize that if they wait for a long time, eculizumab efficacy disappear. So I think they started the next treatment, most likely the rituximab, without washing period. That's my, although I do not remember the detail, but that's my guess. Yeah.
Perhaps in the interest of time, let me conclude this plenary, and thank you very much, Professor Fujihara, and let me invite the chairpersons for the next plenary.
Good afternoon. Our next lecture in post-lunch session is Treatment Response and Prognostic Factors in Multiple Sclerosis by Professor Xavier Montalban. Professor doesn't need a formal introduction. It has been introduced in the morning. So over to you, Prof. Xavier.
Thank you very much again for allowing me to join this meeting. And the topic of my talk is treatment response and prognostic factors in multiple sclerosis. This is my disclaimer slide. So it is very clear that we need in clinical practice, we need better prognostication. So when we have a group of people with a disease, we would like to know who of them will have a good prognosis, who of them will have a bad prognosis. I wonder if I can have the trick that you did for me earlier with a pointer. Thank you. So, and oh, yeah, here it is. Thank you. So the same happens in clinical trials. So you have inclusion and exclusion criteria. You are supposed to have an homogeneous population, and then you have the outcomes. The trial may be positive as a group, but then, of course, you would like to have to know who will have a good response to that specific treatment, who will have a suboptimal response, and who will develop treatment failure, in fact. So this is personalized medicine, and in oncology they know very well what is that, and they have a specific definition. It's a process that analyzes a person's molecular information. They use very much pharmacogenomics. We are a little bit far away from that nowadays, so we would like to have this. If you have that mutations, BRCA1, BRCA2, you have very high risk of breast and ovarian cancer, so you take measures on that. But personalized medicine, in essence, is the combination of the best available information from a variety of sources. And I think this is what we do in clinical practice. We don't have precision medicine, but we do have personalized medicine. And for personalized medicine, we need an early and accurate diagnosis, as we discussed this morning. Then we try to establish a prognosis. We balance risk and benefits of a specific therapies. We try to apply the most personalized treatment, and then, and very importantly, we monitor treatment response. Is this important in the clinical practice? Yes, it is. This is a paper we published a couple of years ago, and we observed that from Poster to McDonald 2017 criteria, we observe a 70% reduction in the median time from CIS to MS diagnosis, and an 82% reduction in the median time from CIS to treatment onset. Because of these factors, probably because of the use of different diagnostic criteria, and also because of early diagnosis and early treatment, what we observe, and this is clinically relevant, is that the probability of reaching an EDSS of 3 at the age of 40 decreased from 0.86 to 0.02, which is quite significant. The same year, this Italian group published a very similar paper. This is a retrospective multicenter observational study from the Italian MS registry. and they observe a 50 to 70% reduction in the risk of disability over time. Just another piece of information. So early treatment, we know, I think we all agree, is very important. But it's not just within the first 2 years. It's not just within the first 5 years. In this paper that Álvaro Cobo published last year, we divided our CIS patients in 3 groups. The first group started treatment after 6 months after the CIS. And the last group started treatment after 1.5 years. So it's not a big difference. However, results were quite different. So starting earlier produced a better prognosis in different outcomes. Time to reach EDSS-3, time to reach EDSS-6, time to reach SPMS. So it's not just early treatment, it's very early treatment. And again, and we comment this paper this morning, the ARISE study using dimethyl fumarate in patients with RIS demonstrated an 80% reduction in the conversion to clinically definite multiple sclerosis, and the same for teriflunomide. Early is important, but high efficacy is also important. Just this paper published a couple of years ago, Swedish versus Danish. Swedish very aggressive, let's say, using a lot of rituximab. Danish at that specific time point, quite conservative. The difference in the prognosis was quite clear. I learned that the Danish have changed completely their practice now, and they are using as well a high efficacy from the very beginning. This is what is happening in our center in Barcelona, THEMCAT. So we had in March 23, 1,378 patients with CIS seen during the first 3 months after the first symptom. 60% of those fulfill McDonald criteria for MS, and 75% started treatment, which is not really very nice in the sense that, in fact, 25% of patients with multiple sclerosis didn't start treatment in our center. And we are supposed to be, you know, quite, let's say, aggressive in that sense. We are just checking what happens here. But the message here is that if you look to the evolution of the treatment strategy over time, I'm talking about the first ever treatment, you realize that now in 2022, most of the patients started with very high efficacy. That means monoclonal antibodies. And some of them as well with high efficacy. That means cladribine and S1P modulators. And very few with intermediate efficacy, the others, and DMDs. So, okay, if we want to treat early, if we want to choose between different medications, we would like to establish a prognosis. And I will follow this figure that we published, Dalia Rothstein from Toronto and myself published a few years ago. Here you have a number of poor prognostic factors. And I will mention first the demographic and environmental factors. Age is a prognostic factor for disability, and if you have a late onset MS, you will reach a sustained disability sooner. But there is a trick here, because the kids, sorry. This is the childhood onset MS. They take 10 years longer to reach SPMS, but reaches this landmark 10 years younger than adult onset MS. So at the end, they reach a certain degree of disability early on. What about gender? Well, women has more incidence of MS, as we all know. They tend to have more relapses, more focal inflammatory activity than men. But disability progression is superior, is higher in men. What about race and ethnic disparities? This is a nice paper coming from US. You can see here that MS prevalence is highest in white and black persons, was lower in Hispanic individuals, and lowest in the heterogeneous group of Asian Pacific Islander, residing in Southern California, of course. And the prognosis for conversion, you can see here that non-whites are more likely to experience a second event than whites during short-term follow-up. So it looks like non-whites have a worse prognosis. And in fact, the North African patients with MS had a clear, more aggressive prognosis than the white people. And mortality as well. So everything goes in the wrong direction if you are not white. However, it's just race. So what about the social determinants of health? What about the economic stability, the access to health care, the neighborhood where you live, etc., etc., etc. And this is really important. In this, I think, key paper, what they demonstrated is that the black race and Hispanic ethnicity are not significantly associated with EDSS if you compensate for social differences. And I think this is very important. So it's important because you can prevent the bad prognosis in patients with differences in race. What about environmental factors? Of course, we know that low vitamin D levels increase susceptibility and probably they produce a bad prognosis in our patients. Smoking as well. Diet, we don't know exactly what is the best diet for MS, but there are a number of papers recently indicating that the Mediterranean diet, again, is the best one for MS patients. The body mass index, we have to take care of it, and the exercise as well. And then comorbidities. Comorbidities are associated with higher relapse rate and higher disability, and they are treatable conditions. So, and in a number of MS centers around, we now have specific clinics dedicated to treat comorbidities and also to treat environmental factors. What else we have? What about clinical factors? So the relapse topography, we know that pyramidal and cerebral presentation seem to have a more aggressive evolution, although we have to be a little bit careful with this. And I will give you one example. This is the classical natural history study by Brian Weishenker when he was working in London, Ontario. He showed here a number of good prognostic factors, one of them being the visual onset of multiple sclerosis. And then many years ago, we published this paper, is optic neuritis more benign than other first attack in multiple sclerosis? And for that question, we studied 320 patients with CIS, almost 40% of them with optic neuritis. And it was true that a lower proportion of patients with optic neuritis converted to CDMS in comparison to others, CIS, spinal myelitis, brainstem, and others. However, when we look to the MRI, 50% of the patients with an optic neuritis had a normal brain MRI. So at the end, we observed that the topography was not the real important prognostic factor, was the abnormalities in the MRI. What about the number of relapses? The higher number of relapses you have, the worse prognosis you will have. And this is true mainly during the first attacks, during the first 2 years, but I would say this is true over the whole course of the disease. A longer interval from first to second attack gives you a better prognosis, and incomplete recovery from first attack gives you a worse prognosis. If you have cognitive involvement and also fatigue at the time of the CIS, the prognosis is going to be worse as well. And of course, and this was mentioned this morning, if you have disability progression early on, and this is coming from our center, Carmen Turbi, the first author, we observed that having PIRA, and PIRA is present in 25% of our CIS cohort, Having PIRA versus no PIRA increased the hazard ratio to suffer progression of disability. So the hazard ratio is 7.9. And if you have early PIRA, this is even worse. So disability progression during the first years of the disease is going to give you a bad prognosis. What about MRI? MRI is key. We have been discussing this morning as well, coming from Queen Square, London, UCSF. The majority of CIS patients have higher, more than 10 lesions in the MRI at baseline, but this is an important factor to reach EDSS-6. So again, the higher number of baseline T2 lesions you have, the worse prognosis in the long term. And this is true as well in our series in Barcelona. So EDSS at year 5 correlated with the number of baseline lesions, as you can see here. Another paper as well, coming from Queen Square, indicates that the increase in the T2 lesion volume during the first 5 years is important for the long-term prognosis. And the number of patients developing SPMS is higher in those patients who had an increase in the T2 lesion load during the first 5 years of disease. Once and again, what happens at the beginning of the disease is important in the long-term prognosis. So that means that we have to make the diagnosis early, and we have to treat early, and probably with high efficacy therapy. What about the topography of the lesions at disability accumulation? The presence of infratentorial lesions on baseline MRI scans, and also the presence of spinal cord lesions in patients with CIS gives you a bad prognosis in the long term. And also, and this is quite logical, the presence of brain atrophy, you can measure the brain atrophy as you wish, the thalamic volume, the whole brain volume, the spinal cord atrophy, whatever. There is a direct correlation between brain and spinal cord atrophy and long-term disability progression. Now, and has been discussed this morning as well, we know that there are some slowly expanding lesions with a microglial rim. In many cases, there is an iron deposition within and outside microglia, and these are we can measure some of them as PRLs, and apparently the presence of PRLs also indicates a bad prognosis and a higher probability of increasing disability in the future. Here you have very nice examples, courtesy of Alex Rovira, and the cells as well. So this is a patient with a very rapid. This patient was treated, by the way, with rituximab, so with anti-CD20, but the progression was very fast. In just 3 years, he progressed very much, and you can see the level of cells that this patient has, so very impressive. And also we have to be a little bit aware of this radiological phenomena. So what else we have about from demographic, clinical, MRI? Well, neurophysiology. We have Letitia here and Giancarlo Comi, and we published this paper years ago indicating that if you have three evoked potentials abnormal, the prognosis is going to be bad in the long term. So you can see the hazard ratio here to reach an EDSS of 3 over time. And the problem is that you only find 3 evoked potentials abnormal in 8% of the CIS population. What else we have? Biomarkers, biological biomarkers. CSF, of course, is very useful for clinical diagnosis. What about prognosis? This paper coming from our center, published in Brain years ago, showed that in the multivariate analysis, that the presence of oligogonal bands gives bad prognosis in the long term. And we knew that already from other series, of course. In some centers, mainly in Madrid, they say that the IgM oligogonal bands produce also a bad prognosis in the long term. We published a number of years ago that the elevated MNA1 specific immune response predicts disease conversion, but not only disease conversion, but also, let me just go here, progression in patients with CIS and during over time. Chitinase 3-like-1 levels in the CSF seems to be independent risk factors for conversion to MS. Of course, this is CSF. In the clinical practice, everything in the CSF is more complex to be used in our office. Let's see if we can measure this in serum as well. Neurofilaments, we already talked about this morning, predicts conversion as a group, but also the serum neurofilament is associated with EDSS outcomes up to 11 years of follow-up in a number of papers. I'm just going to show you one or two. And also GFAP levels correlated with progression, particularly in non-active patients, as you can see here. And maybe a biomarker in patients who have no non-focal inflammatory activity. And in this interesting paper, recent one, if you have an increase in the levels of GFAP and also an increase in the levels of neurofilament, the prognosis is not going to be really good. Well, 2 years ago, we thought that we didn't have any genetic marker for disability progression. We had about 200 genes indicating a higher susceptibility to suffer multiple sclerosis, but nothing in relation to disability progression. But last year, Sergio Barancini and co-workers published that there are 2 alleles that may be related to disease progression, and this opened the window of studying the mechanism of how these genes works, and perhaps trying to get some molecules targeting some of the functions of these genes. So the treatment decision-making process is not always easy. I always say the same, that in our center there are about 18 neurologists. Every single case of a patient starting DMD or switching DMD is discussed in a general meeting. And sometimes it's very easy, sometimes it's very difficult. Everybody is very opinionated, and all of us, we are expert in multiple sclerosis, and we have great discussions trying to identify the best option for one specific patient. So at the end, the best solution will be to combine all these biomarkers in models. And we published a couple of predictive models for prognosis in multiple sclerosis. This is the last one. Let's see how it works. This is our deep phenotype inception cohort of patients with CIS, and we took into consideration a number of MRI data, biological markers, demographics, of course. And this is what we have, is a spider sort of prognostic figures. And you can, in one specific patient, you put into the model, and you have the risks at 10 years of developing PIRA, EDSS3, etc., etc., etc. So, okay, you have the prognosis. You have an early diagnosis, very accurate diagnosis, and then you need to personalize the treatment. And we take into consideration all this. I'm not going to discuss this. This morning, Professor Hartung gave a very good talk on treatment. For treatment response, we are still using in sometimes the Rio score. Rio score is now, to me, Jordi Rio is my colleague in Barcelona, but I don't think Rio score is working anymore. It was very conservative. I don't know if you remember that, but you know, 1 relapse or at least 1 point confirming EDSS or at least 3 active lesions. You need 2 out of the 3. Then a number of other scores appeared in the literature, But the one I like, the paper I like more is this one by Jordi Rio, published in Multiple Sclerosis. We had two populations, one with a very long-term follow-up after 8 years, very low dropout rate, and then we measure the clinical activity and MRI activity after 1 year, and we had outcomes after 8 years. And what we found, the outcome was serious one. Well, not very serious, but 2 points EDSS increase a step. Two steps increase in the EDSS. And as you can see here, if you have 1 or 2 new T2 or 1 GAT lesion alone, well, apparently nothing happened. But the EDSS was just after 8 years and was just 2 steps. But then if you look to the patients after 12 years of follow-up, you realize that everything matters. So 1 relapse, 1 new T2, etc., that matters. So probably the best thing to achieve is the NIDA status, right? So free from disease activity, no relapses, no new T2, no GAT lesions, no disability progression. It's very rare. Only 8% of patients after 7 years maintain NIDA status. This is mainly with moderate medications. And then let me just show you new data which has not been published yet. This is the prediction of treatment response in relapsing remitting treating with oral DMTs by Agustin Papola, one of our fellows, SLCTRIMS fellows. I'm going to skip all this. Well, just to indicate that if you have an EDSS, a real score of 1 or 0, here you can see still after 3 years the probability of reaching some degree of EDA, of activity, is very high. So 28% or 68%, I can read very well. Yeah, so the real score is not working well. This is my message here. So another piece of information, and this is by Victoria Fernandez, another SLCTRIMS fellow. She studied a number of patients treated with high efficacy medications, and I just would like to highlight this. So an increase in the neurofilament levels at year 1 predicts loss of NIDA3 at year 2 in patients under DMT, naive and previously treated, and also in patients who were treated with high efficacy medication. So you can be NIDA3, but then you better check the neurofilaments levels. And I think that will be the NIDA4, not the atrophy in the brain, but the neurofilaments status. And I will skip the other one. So these are the take-home messages. So disease heterogeneity in MS complicates an individualized prognosis. Predicting at disease onset which patient will develop further attacks or disability underscores the need for prognostic biomarkers. When combined, biomarkers already in use in clinical practice have different degrees of prognostic impact. To fine-tune the individualized prognosis, many other biomarkers are under study, and a number of them show promising results. And I would say that neurofilaments and GFAP will be key. And I think with this, we'll be approaching to the concept of personalized medicine, not precision medicine, but personalized medicine. And I thank you very much for your attention.
Thank you very much, Professor Montalban, for that very elaborative talk. So in the interest of the time, we can maybe take up one question.
Thank you very much, Xavier, because you provide us with a very large set of information and with a very clear message that MS is not so unpredictable when we have been used to be taught some years ago. So one of the key problems, and I would like to listen to your opinion about that, is that here we are assessing the prognosis modified by intervention. So that if we are exploring the prognosis after a very high efficacy treatment, we should cancel a lot of predictive factors because are those who are responding to a not so strong type of impact. Then how should we then think in the future to have a prognosis for a specific type of intervention or to have any other strategy? Because that's make a bit complicated our life, the fact that maybe you are using different treatments in one after the other. That makes then extremely complex to have any information.
Thank you, Giancarlo. I think you're very right. So, in fact, you realize that when you have patients with bad prognostic factors and they are treated, the prognosis in the long term is much better than those with better prognostic factors who were not treated. So it's more important to be treated early and to be treated with high efficacy therapy that having bad prognostic factors. To your second part of the question, I don't know. I think now we don't have elements to say for that specific population of patients I will use this, and I'm not talking about other aspects such as a wish to become pregnant, comorbidities, etc. I'm just talking about efficacy in the long term. I would say that we're just saying, well, the highest efficacy treatment you use, the better prognosis you will have in the future. But, this is what we have nowadays. Yeah.
Okay, so thank you very much. Let me conclude this plenary and let me invite the chairpersons of the next plenary to take up the seats. Thank you.
Good afternoon to everybody, and thank you so much for staying back till the end. So we come to the last plenary of the day. So we are going to have a talk on pediatrics today. So it's our pleasure to invite Dr. Tanuja Chitnis from USA to talk to us on pediatric multiple sclerosis in 2024, progress and challenges. Over to you, Professor. Sorry, Professor, we can't hear you. I think you're muted.
Here we go. Can you hear me now?
Yes, we can hear you. Thank you.
Okay, wonderful. So thank you for the opportunity to speak, and thank you very much to the SLCTRIMS organizers. It's my privilege to speak to you today on pediatric multiple sclerosis, progress and challenges in 2024. My name is Tanuja Chitnis. I'm a professor of neurology at Harvard Medical School, and I've been working in this field for over 20 years. So I'm first going to share with you a case of a young man who I have had the privilege of caring for since age 11. So he was first diagnosed with multiple sclerosis at the age of 11. At that time, he was a student, he was a soccer player. You can see here his MRI, and he has a number of lesions, very typical for multiple sclerosis, and minimal brain atrophy. During his disease course, this was in the very early days of disease-modifying therapies, he was first treated with beta interferon. He, of course, did not like the injections. It was quite challenging in terms of adherence to have him take these daily or every other day injections. And for a period of time, he decided to stop treatment, especially when he turned 18. So he was off treatment for 4 years. Then he agreed to restart treatment. He agreed to restart an oral therapy, dimethyl fumarate, for 4 years. He had several new lesions while on dimethyl fumarate, and we were able to convince him to go on to higher efficacy treatment with ocrelizumab, which he's been on ever since. However, here at the age of 29, he has a number of lesions. As you can see on his brain MRI, he has generalized atrophy, cortical atrophy. But despite this, he is doing quite well. And in his own life, he is a father. He got married, and he also is working full-time as a mechanic. So I think this case illustrates the importance of early, effective treatment in pediatric multiple sclerosis, and how do we achieve this in this young population? Unfortunately, 15 years ago, we did not have as many options as we do today, and I wish I could have offered him high efficacy treatment at the very onset of disease. So we've made a number of advances through international collaboration in the pediatric MS field, and I'll highlight some of these advances. One is diagnostic criteria for pediatric multiple sclerosis, the understanding of risk factors for MS, including genetic and environmental risk factors, which we know now apply to pediatric multiple sclerosis. And also, we've gained a great deal of understanding in the similarities and differences between adults and pediatric MS patients. And these are important when we consider treatment choices as well as ongoing management. And then we've made a great deal of advance in disease-modifying treatments for pediatric MS, which I'll speak about. So what are the basics? Who gets MS in childhood? So we know that about 5% of all MS cases are pediatric in onset, and the prevalence is approximately 1 to 5 per 100,000 children. So pediatric MS is rare. It is more common in families with multiple sclerosis and autoimmune diseases, and many of these children do have a family history of other autoimmune diseases. About 90% of our cases are post-pubertal or older than age 11. And this is important since many of our patients will present in their teenage or adolescent years. And of course, this is a challenging period overall, but even more challenging when you're dealing with a diagnosis of MS. Importantly, we rarely see children under the age of 11 with pediatric MS, and you must think of other differential diagnoses if you do have a very young onset case. In general, our patients present with similar symptoms as adult MS, optic neuritis, transverse myelitis, motor, sensory, cerebellar symptoms. And the differential diagnosis that you must consider in children, especially younger children with the onset of what looks like MS, are the following: acute disseminated encephalomyelitis, MOGAD, and NMOSD disorders. So to illustrate this is MRIs from patients with MS. In the middle here, we have a pretty typical pediatric MS case, our young man who has periventricular lesions. In contrast, our patient with ADEM, or acute disseminated encephalomyelitis, has more subcortical lesions, they're fluffier and more diffuse in nature. And our patient with MOGAD, in this case, has encephalitic type of lesions, perimeningeal lesions, and has bilateral optic neuritis with very swollen optic nerves. So this is just a snapshot of some cases. Of course, there is quite a great deal of heterogeneity in the presentation of MOGAD, but this must be considered in any young patient with onset of demyelinating diseases. So we know that McDonald criteria are quite effective in diagnosing MS, and these are the 3 pillars of diagnosis: our clinical criteria, which includes clinical attacks, and evidence of no better diagnosis. So this is very important, especially in children, again, to rule out other entities that can mimic pediatric MS. We have MRI criteria for dissemination in space and time, and also additional criteria including oligoclonal bands, and possibly in the future more biomarkers might be incorporated into the McDonald criteria. So how do these apply to children? So they apply quite well. And in addition, the International Pediatric MS Study Group has developed diagnostic criteria in 2012, which distinguished encephalitic events, so those that have an ADEM-like presentation, from those without encephalopathy. So acute disseminated encephalomyelitis in children generally presents with encephalopathy, and we must distinguish that from first CIS events, which are more typical for pediatric multiple sclerosis. Once you've done that, then you can apply the McDonald criteria, also ruling out other entities such as MOGAD, and these apply quite well to children. So we've also learned a great deal about the risk factors for pediatric onset MS. We know that genes contribute, and the HLA-DRB1 1501 risk allele is certainly the greatest contributor. to pediatric MS risk, as well as the over 200 non-HLA MS susceptibility alleles. This has been shown now in several studies. We also know that exposure to environmental factors, including Epstein-Barr virus, is present in 99% of pediatric MS cases, and other risk factors, including low vitamin D, exposure to tobacco smoking through parental smoking generally, obesity and dietary factors, as well as the gut microbiome, are emerging as risk factors for pediatric multiple sclerosis. The period of puberty seems to be an important turning point, and as I've mentioned before, about 90% of our cases are post-pubertal in onset. So why is that? Estrogens, we know, play an important role in the immune system, and this combined with the genetic and environmental risk factors may lead to the immunobiology of multiple sclerosis. So to illustrate here the demographics of typical pediatric MS cohort, this is from our US network of pediatric MS centers database, which collects patients from over 12 sites across the US. And you can see here that the majority of our cases are 10 and older, and especially as we start into adolescence, the male to female ratio changes dramatically with an increased prevalence in females, nearing that of the adult population. So we certainly think that hormones play an important role in the onset of MS in general, and especially in the onset of pediatric MS. We've also shown through our US network database that obesity and a higher body mass index is a risk factor for pediatric multiple sclerosis. And about 50 to 60% of our pediatric MS patients are overweight or obese. And this applies to both boys and girls. So we do know in general that higher BMI is a risk factor for MS, and this has been shown in adults that adolescent or a BMI at the age of 18 is a risk factor, and this applies especially in children. So given the increasing onset of obesity and earlier menses and menstrual periods worldwide, and this is across many different regions of the world, it may be not surprising that we are seeing more cases of pediatric onset multiple sclerosis. So it does beg the question, is pediatric MS closer to the true biological onset of MS? And when I see patients in my adult clinic, many of them will have evidence of brain lesions, T1 black holes that probably were present or definitely were present prior to their first clinical presentation. But possibly our younger patients may not have this clinically silent prodrome that adult patients do, and may be presenting closer to the true biology of MS onset. And so I think it's an important opportunity therapeutically, because if we can stop disease in these young patients as early as possible, we have a chance for a healthy and very neurologically unimpaired life. So what we've also learned about pediatric MS compared to adult MS is that there is a higher relapse rate in children compared to adults. And this is now borne out in several studies. And other groups have also shown that there is a higher incidence of new MRI lesions in pediatric MS compared to adult MS. And I think the relapse rate here is illustrated with the pediatric and then the adult relapse rates over at least 2 years. Although our young patients are having more relapses than adults, their recovery from relapses are typically better than adult patients. And so there's somewhat heartening. We do again have the ability to repair. And if we can harness that in young patients going forward, maybe this could be also a way to preserve neurological function long term. However, inflammatory disease on a young brain can significantly impair cognition, and we do neuropsychological testing in our young patients at onset and at least every 1 to 2 years, and offer them support in school if they are having, if they do have challenges cognitively. And some of these challenges cognitively include complex attention deficits, deficits with naming, recall, processing speed, and this can be pervasive. And we've shown that our young patients, when they do grow up to be adults, have lower SDMT or processing speed scores than adult onset MS patients. So I think these are all consequences of inflammatory disease on a developing brain, on a brain that is continuing to learn, and this is a critical period, again, that we need to control this inflammatory disease activity. So what about long-term outcomes in pediatric MS? We know that our pediatric MS patients will have a higher disability score at a younger age than adult onset patients. And so my 25-year-old will have more disability if they had pediatric onset MS than my adult patient who's now presenting for their first attack at the age of 25. We've shown that pediatric MS patients have lower cognitive scores than adult MS patients when they are adults. And we've recently shown that younger age at onset is associated with a lower likelihood of employment at the age of 50. And so important not only for the short term in school, but also for long-term and gainful employment. Our pediatric onset patients have both brain atrophy and failure of age-related brain growth. And so again, the important consequence of treatment must be explored. So a recent study explored how do MS patients acquire disability. And I like this study very much because it looked at a concept called PIRA, which I think you've heard about in this conference, progression independent of relapses, as well as relapse-associated worsening. The majority of our adult patients accumulate disability through PIRA. However, our pediatric patients were shown to accumulate disability through RAW, or relapse-associated worsening, predominantly. And so again, very important to stop these relapses, prevent disability accumulation in the short term, and prevent disability in the long term and improve long-term outcomes. So where do we stand with treatments? So about 12 years ago now, we convened a group in Washington, D.C. to discuss how to move forward treatments for pediatric multiple sclerosis, including clinical trials. And we had a number of stakeholders at the table, and we agreed upon some basic study outlines for pediatric MS trials, and also including important factors like cognitive batteries in these trials and quality of life, and also ensuring that they were feasible to conduct. So since then, we've had one phase 3 trial, which has completed. That was Gilenya. And we have actually 2 phase 3 trials that were completed, Gilenya and Aubagio, and one that was approved in the US for use by the FDA. Several treatments have been approved by the European Medicines Agency on the basis of phase 2 and phase 3 trials, as well as historical results for beta interferon and Copaxone. And so it is heartening that we are seeing advances in both trials as well as drug approvals for pediatric multiple sclerosis. And this is continuing now with many trials launched for the various B-cell therapies. And I hope that we will have these available and approved through regulatory agencies soon. So the Paradigms trial compared Gilenya or fingolimod to beta interferon 1A or Avonex, and this was a pivotal trial because it showed that there was an 82% reduction in the annualized relapse rate with a fingolimod arm compared to beta interferon 1A. And what I like to tell my families and my patients is that in this study and with fingolimod, 86% of these children remained relapse-free over a 2-year period compared to 39% in the beta interferon 1A arm. So it is very good in terms of relapse control. It was also a paradigm in terms of being able to conduct a clinical trial and also have long-term safety data that could really inform care and help us to advise our patients long-term. Health-related quality of life scores were improved not only as reported by the patients, but also by the parents. And I think the change and difference from using injectables and injections to an oral drug was really a major step forward in the care of patients. However, we did note that brain volume loss still continued, and even in the fingolimod arm, especially when we looked over the longer term. And I will note that the median disease duration at study entry was 2.1 years, and it did range from really onset at first diagnosis and first symptom to 10, almost 11 years. And so I wonder if we had been able to treat our patients at day 1 with a high efficacy treatment, if we may have been able to prevent this brain atrophy from occurring long term. So several other studies have completed. CONNECT compared dimethyl fumarate to beta interferon 1A, and it was found to reduce new T2 lesions, as well as the adjusted annualized relapse rate in the DMF arm compared to beta interferon. And this has now been approved for use through the European Medicines Agency. And however, some of the adverse events also were noted, and that included the typical dimethyl fumarate symptoms that we see in adults, including abdominal pain and flushing. So again, important to note that there are side effects, but these studies and trials do help advise us in terms of the incidence in which they occur in children. Natalizumab is a highly effective treatment, and the Italian group pioneered by Angelo Ghezzi has published a large cohort of 101 cases showing very good control and the high proportion of relapse-free patients, as well as limited EDSS progression. So again, a highly effective therapy, particularly on clinical outcomes. There were patients who continued to have new MRI lesions, but overall highly effective. However, one of the limitations of this treatment is that JCV positivity does increase the risk of PML, and there may be a higher incidence of JCV antibody positivity in pediatric MS patients compared to healthy children. And of course, we screen for this at baseline when using this drug. Natalizumab has been tested in a PK or pharmacokinetic study in children, and overall very good PK results in our adolescents, age 10 or 13 and older. However, the results in our younger patients were somewhat variable, and the 10 to 12-year-old group is here. And so we do need to understand a bit more about the PK and the right dosing in our younger patients who are younger than age 10. The TerraKid study looked at teriflunomide compared to placebo. It did not meet its primary endpoint, which was time to first relapse. However, looking at the combined outcome of MRI, high MRI lesions, as well as new relapse, there was a significant difference in the teriflunomide compared to the placebo arm. And this drug has been approved by the European Medicines Agency. There was a significant reduction of new T2 lesions and new gadolinium-enhancing lesions, as would be expected in the teriflunomide arm. And so, again, another option for treating children, an oral drug, and so this may be a nice option for those who don't have or can't take injectables or infusions. So anti-CD20 therapies have been a major advance in multiple sclerosis. There have been a number of studies now initiated in children, including clinical trials. And we have different forms, of course, of anti-CD20s, rituximab, ocrelizumab, and ofatumumab, which is given subcutaneously. So we also must be cognizant of the risks of high efficacy treatment, and we looked at COVID outcomes in our pediatric MS database from the US network, and we did find that B-cell therapies were associated with a higher risk of COVID hospitalizations in pediatric MS patients, and also combined with those with other demyelinating disorders. So a slightly higher risk of hospitalization, including ICU stays, in our younger patients, and we must be cognizant of that and advise our families accordingly. So a number of clinical trials have been launched for B-cell therapies. Operetta is examining the safety of ocrelizumab compared to fingolimod. This is a non-inferiority study, and so another advance has been in the conduct of clinical trials. Now we're comparing two high efficacy treatments. There's no patients who will receive placebo in these trials or a known lower efficacy treatment. And so the goal is to show non-inferiority, and we have a number of outcomes, including, of course, relapse rates and MRI outcomes. The NEO study is comparing ofatumumab and siponimod to fingolimod. And again, this is a non-inferiority study, so all patients will get drug, which seems to be highly efficacious, and that is a benefit and will help and has helped enrollment. Again, a number of outcomes that we will learn a great deal from. So what about the real-world use of disease-modifying therapies? There has been a major shift away from injectable therapies in the past 5 years or so, and a shift towards increasing use of oral and intravenous therapies for pediatric MS patients. And so I'm sure if this extended out to 2024, we would see most patients are going to be on either orals or intravenous therapies, even though some of these are not approved across different world regions, including the US. So my approach to treating children with MS is that given it's a highly inflammatory disease, I tend to start here with the highly effective therapies. There are, of course, risks to these therapies, which are on the top of the pyramid, and I really reserve any of those for patients who have broken through and failed typical high efficacy therapies, including fingolimod, natalizumab, and B-cell therapies. I don't use alemtuzumab as much in our pediatric patients. And however, we must manage the risks and benefit ratio. And I think, again, counseling our patients appropriately about the risks of treatment and immunosuppression is something we continue to do on a daily basis. So how can we also monitor patients as they are starting on treatments and understand their prognosis and longer-term outcomes? We've heard a great deal about neurofilament light and the GFAP biomarkers, and there has been a nice segment earlier in this session about these biomarkers, so I won't go into detail. But these are now commonly measured in the plasma or serum, and we have highly sensitive assays such as Simoa, which allow us to detect these biomarkers. And neurofilament reflects axonal or neuronal damage. GFAP reflects astrocytic damage and seems to be highly correlated with the onset of progressive MS. So we've conducted studies looking at NFL levels in our pediatric MS patients. We found, of course, that these were higher in pediatric MS compared to healthy control. They were higher in patients with active relapsing disease compared to those in remission, and they were suppressed with treatment. However, NFL was still higher in our pediatric patients who were in remission compared to healthy controls. And they were 577% higher in our active patients compared to our controls. So we're still not achieving normal levels of NFL in our pediatric MS patients despite treatment. And so I think and those in remission, so I think we need to continue to explore ways of suppressing inflammatory disease. We also found that both NFL and GFAP were associated with greater disability or EDSS scores, so this may be a way to help monitor and maybe prognosticate for higher disability scores. Other groups have found higher CSF levels of NFL in pediatric compared to adult MS patients. And you can see here our children have much higher NFL levels in CSF compared to the adult patients, which really speaks to the inflammatory nature of disease and probably highly destructive nature. And so I think this is a very important finding and speaks to the importance of controlling disease with treatment. And the group from Germany, led by Peter Hupke, have shown that pretreatment NFL levels predict treatment response in pediatric MS patients. And so we can use this now to help monitor patients' response to disease-modifying therapies. In the teriflunomide study, NFL levels were monitored, and they were indeed suppressed, especially in the extension arm, where patients were followed longer term. So it may take some time to fully suppress NFL levels, and this again requires sustaining treatment and making sure that patients are adhering to ongoing treatment. So I often like to have this discussion with my patients and families about what are the goals of disease-modifying therapies, since it is somewhat confusing. It's clear that our treatments prevent relapses and prevent new MRI lesions. However, we would like our treatments to also prevent disease progression, PIRA, improve existing neurological symptoms, improve cognitive outcomes and quality of life, and essentially achieve NEDA or no evident disease activity. So in our US network, we surveyed our patients and asked them whether they agreed with these outcomes of treatments. And the majority did agree that treatments should prevent relapses and that they also wish that treatments could improve physical symptoms such as pain, vision, or fatigue and prevent any new symptoms from occurring. So I think in general, our patients are in line with our goals, and I hope that our treatments will improve, will continue to show benefit. Our patients also had good satisfaction overall with their care, which was heartening to see, and most were seen in specialized MS centers, which has been a real advance for pediatric MS. So shared decision-making in the pediatric MS space, this is important to involve not only the parents, but also the adolescent, the teenager themselves, and they need to have a say in their care and be on board with the treatments that we're prescribing. And so helping patients to explore and understand options, preferences, and also understanding the potential adverse events, ensuring that they understand what these treatments are all about. Medical literacy is important, and that all parties are involved in the shared decision-making process. So in terms of efficacy and adherence, again, our adults and our teenagers with MS largely agreed that treatments should improve and manage their symptoms. But they also did acknowledge that it's been challenging to deal with some of the negative side effects of MS therapies, sometimes difficult to take pills, and swallowing pills might be challenging for some. It's challenging, of course, to take injections, and some reported challenges in going to the clinic or hospital for infusion. So I think this speaks to individualizing care and finding the right option that works for that individual patient. So in general, my principles for treating pediatric MS are to use evidence-based medicine, share decision-making, informed care, articulate the goals of care for parents and for the child or teenager, high efficacy treatment at diagnosis. And I can't emphasize this as enough. We have now evidence that high efficacy treatments are effective and safe in pediatric MS, and we must use these at diagnosis to control the highly inflammatory nature of this disease. So careful monitoring for disease activity in PIRA, and we do this, of course, with clinical examinations and MRIs, especially after starting a new disease-modifying therapy, but there may be an important role for serum biomarkers, especially in pediatric MS. And then we need to develop and continue to improve strategies for reducing adverse events. So some of our goals in the near future, and this is really where we need to make progress to optimize treatment for pediatric MS. We need faster approval of DMTs for pediatric MS, and these trials are on the way. Improved access to disease-modifying therapies. The current therapies, they are challenging to obtain in some world regions. There is an expense associated with these. Some insurers don't approve disease-modifying therapies right away, and we need to go through a long process which delays onset and treatment. So we do need improved access for DMTs, as well as information for pediatric MS. And I think disseminating easy to understand information for families in multiple languages is critical. We have to be on the lookout for side effects, including infection, and we've all dealt with the COVID era. And I think also incorporating biomarkers for monitoring disease activity in pediatric MS is important, and this will be the subject of many studies to come, including in the clinical trials. And we need more information for optimal symptomatic treatments for pediatric MS patients. Our young patients do have fatigue, depression, and other symptoms, pain as well. And so this we need to pay very close attention to. And then there may be options and opportunities for innovations for safe, effective therapies for the earliest forms of disease. And some of my patients say, well, why can't I just take one pill and be done with this? And this may be the future. So hopefully we will eventually have disease-stopping therapies, not just disease-modifying therapies, but disease-stopping therapies for MS, particularly in this earliest form. So hopefully I've been able to share with you some of the advances, and maybe these will help our young patients, including this young man, live a very healthy and fulfilling life. So thank you from our Pediatric MS Center at the Massachusetts General Hospital, and also from our International Pediatric MS Study Group. Happy to take any questions.
Thank you very much, Professor Tanuja Chitnis, for that excellent talk on pediatric multiple sclerosis in 2024, the progress and the challenges. Are there any questions to Professor Tanuja? We can, yes.
Thank you, Tanuja, for the very excellent talk, and you presented all available data of issues related to pediatric MS. My question is, if your pediatric patients reached a certain age, for example, 18 years old or something, do you automatically refer those patients to adult neurology departments? How do you do that?
Yeah, so thank you, Kazuo, and greetings to you. So I actually have the luxury of being able to transition our pediatric patients slowly, and we in the US can transition them at the age of 20 or 21 in most centers. And so I do give the patient the option. Oftentimes these patients are diagnosed in their teenage years at the age of 14, 15. They're just getting established on treatment. They're just getting used to the clinical care center and our pediatric MS center, and they don't want to transition right away. Also, they're starting college at the age of 18, and that's a major transition period for them. So I generally keep them in our pediatric MS center until 19, 20, until they tell me they're tired of sitting in that waiting room, and then I transition them to the adult center. That transition period is very important since now they're somewhat independent. They will have to make their own appointments, and so we help to train them on that process so things don't fall through the cracks and we don't have a gap in therapy and management. Fortunately, I see both adults and children, so many of these young patients will transition to my adult clinic and see the same provider, but that may not be the case in every center.
Thank you, Tanuja.
One more question.
Thank you very much, Tanuja, for this wonderful lecture. Peter Hartung, I have one request. Could you discuss the potential role of autologous hematopoietic stem cell transplantation and mesenchymal stem cell transplantation in the pediatric population?
Yes, so greetings to you, Peter. And thank you for those questions. So I have not had a patient who in their pediatric years has pursued autologous hematopoietic stem cell transplantation. However, I have had two patients who, when they became young adults, they said, I'm tired of these disease-modifying therapies. I've had side effects, I've had issues, and I want something that is disease-stopping or disease-ending. And they pursued bone marrow transplant, and it was successful. So 5 years now for one, and about 3 years now for another. Down the road, they've had no further relapses. So I think that young patients, maybe young adults with pediatric onset MS, may be considered for AHSCT, especially if they've had breakthrough disease, side effects, are not doing well on DMTs. So I think that is an option. In terms of mesenchymal stem cell transplantation, there have been a number, actually 2 or 3 trials now that have been completed. This, these trials really, the goal has been to slow or stop disease progression and potentially introduce repair and improvement. Some of our patients do have deficits, and even in their young adulthood years, and so again, I think they may benefit from MSC or mesenchymal stem cell transplantation, especially if it does improve repair and maybe is approved. So in the pediatric years, we would have to do these studies. And, you know, if, again, a product was approved for adult MS, we would be very interested in doing such a study in the pediatric patients who do have sustained neurological deficits.
Thank you very much, Tanuja.
Okay. Thank you very much, Professor Tanuja, once again for answering all the questions. And I think there are no more questions from the audience. And once again, thank you very much.
Thank you.
And we have come to the end of the day 1, and the tea is served outside, and tomorrow we'll be starting at 9 o'clock.